Okay, so scene safety is considered. So obviously, due to the nature of the traumatic situation, so you want to make sure that there's no debris around, cars, any other hazards, etc. So we're utilising our standard precautions. So I've got gloves and glasses on. If the patient is conscious, we're going to explain the procedure to the patient and gain consent. So in this case, due to his condition, the patient is unconscious. We're going to make sure that the patient is in a position of comfort and then that there's adequate lighting. We're then going to obtain a 14 gauge catheter, as well as a one-way valve, antiseptic, alcohol swabs, and tape to secure the needle, as well as making sure that our sharps container is in a reachable position. We're also going to identify, so obviously we would have identified the tension pneumothorax in our rapid trauma survey. So we would also look out for signs and symptoms of a tension pneumothorax when first approaching the patient. So these could be short of breath. When we do our primary assessment and auscultating the chest, we could notice decreased breath sounds. We could notice tracheal deviation as well as distended neck veins. So once all those have been put into consideration and we have confirmed tension pneumothorax, the patient probably would already be on high flow oxygen, but we'll just place him on high flow oxygen like that. And then provide ventilatory assistance if required. We would then expose the side of the tension pneumothorax so we could work with it. So in this case, in a trauma situation, these clothes would be cut off so that we could access the site. We then want to identify the second intercostal space. So second intercostal space and then mid-clavicular line. So around there. We then want to swab the site once we've identified it using aseptic techniques and making sure that we do not retouch the site after it's been cleaned. We then want to use the catheter, so obviously I'm just using a pen in this situation. And also if the patient is conscious, you want to warn the patient because this could be quite painful for them. So once you've got the second intercostal space and mid-clavicular line, you then want to insert the needle at a 90-degree angle of the third rib, and just making sure that you sort of avoid the neurovascular bundle there. And you want to insert it until you feel a pop, and then or hiss, either one, and then you want to slide the cannula off the needle and then place the needle in the sharps container, and then you then attach your one-way valve to the cannula, securing it in place with tape, and then obviously monitoring the patient consistently for other signs of a repeat pneumothorax, which will then have to do another needle decompression.